Hello everyone. In this video, we will discuss one very important topic, that is how to manage constipation in patient. Constipation is a common problem in the patients coming to the OPD. We will be discussing what exactly is constipation, classification, red flag signs if the history is suggestive of constipation, management, and how to give you common medications, practical tips for your general practice, and some real case discussions. Starting with definition of constipation. So the definition of the constipation is less than equal to 3 movements per week. Other definitions can include hard stools or change in the consistency of the stools from the baseline. But this is a basic definition of constipation. Now, let's see how will we classify the constipation. So constipation can be classified as primary. Primary means functional, which include normal transit constipation, slow transit constipation, and rectal evacuation disorders, which we will be discussing subsequently. Other is secondary cause of constipation. Secondary means ki we have some underlying disorder. So we have to treat the underlying cause if we want to treat constipation. So these include common medicines, metabolic causes, mechanical causes, or neurological causes. Functional constipation. Functional constipation is defined by Rome 4 criteria, which include two of the following features, and these are straining, lumpy or hard stools, sensation of incomplete evacuation, or anorectal obstruction or blockage, manual maneuvers like a patient has to take out the stool through manually, a digital evacuation. And these features, A2 features, should be present more than 25% of the time. These should be present. Like out of the 100 days, they should be present for 25 days at least. Fewer than 3 spontaneous bowel movements per week, and loose stools are rarely present without the use of laxatives, and insufficient criteria for irritable bowel syndrome, IBS. And the symptom onset should be more than 6 months. This is the classification: primary, that is functional classification, or secondary causes. So as we have mentioned earlier, primary causes or functional causes can be normal transit, slow transit constipation, or a rectal evacuation disorder. So let's see the feature one by one. Normal transit constipation. Normal transit constipation means that there is a perception of constipation, but the stool movements are normal throughout the colon. So when we do the transit studies, so that will show a normal result. So it's only the perception of constipation. There can be a pain and bloating in these patients. Stress history is commonly positive. And this condition, normal transit constipation, respond well to fiber supplementation and laxatives. Slow transit constipation, as the name suggests, that there is a decreased peristaltic activity that should occur after meals. Normal resting colonic motility, when we check with the stethoscope, is normal, but in response to the food, there will not be any increase in the peristaltic activity. So that is known as slow transit constipation. Main clinical feature, patient will tell you lack of urge to defecate. Generalized symptoms like fatigue will be there. It is more prevalent in young female. There will be a delay in colonic transit. So when we do a colonic transit studies, so there will be a retention of a radio opaque marker. More than 20% of the radio opaque marker will be there. That suggests a delay or a slow transit constipation. And these patients respond poorly to fibers and laxatives. Rectal evacuation disorder. So rectal evacuation disorder, we have to just understand that the a patient, the normal mechanism of the evacuation, once the stool come in the rectum, so this anorectal angle should get straightened so that stool are passed normally, and this puborectalis muscle should relax. So these are the coordination of these muscles which leads to a normal passage of the stool. So there will be inability to coordinate abdominal, rectoanal, or pelvic floor muscles, so that the stool comes normally in the rectum, but the patient is not able to evacuate that stool. So these are pelvic floor dysfunctions or descending perineal syndrome or rectal prolapse. Patient main symptom will be a frequent straining and sense of incomplete evacuation. So this is a very important feature to ask from the patient: incomplete evacuation and frequent straining. That will suggest it to be a rectal evacuation disorder, because rectal evacuation disorder will not fully respond to the fiber supplement or laxative. They respond to biofeedbacks. So the treatment will be different in these patients, and patient will tell you he needs fingers to take out the stools. There will be a abnormal balloon expulsion test or abnormal anorectal manometry studies. Now, classification wise, other cause can be a secondary cause like medications, metabolic, mechanical, or neurological. So these medications: acetaminophen, that is a normal paracetamol tablet, more than seven tablets per week can lead to constipation. Some antacids contain aluminium, so that leads to constipation. Anticholinergic drugs leads to a decreased secretions in the intestine, so obviously constipation will take place, especially in patients who are taking antidepressants. Calcium channel blocker. This is important. Hypertensive patient taking calcium channel blocker, it might lead to constipation. After starting the medication, patient will tell you, "Ki doctor, I have constipation." So change the medication. Calcium supplements, mechanism of the calcium supplements is calcium supplements which contain calcium carbonate. So this is the carbonate component which leads to bloating and constipation issues. So if patient is taking calcium carbonate, change the calcium salt. Iron supplements do cause constipation. Metabolic or endocrine disorders, diabetes mellitus, by causing autonomic neuropathy. Hypercalcemia decreases the excitability of the smooth muscles of intestine. Hypokalemia decreases the resting membrane potential. It makes it more negative, so the excitability become less. Hypothyroidism, pregnancy. Mechanical obstructions include stenosis, very important, colorectal cancer, especially in elderly, extrinsic compression, rectocele, or some strictures. Neurological or myopathic disorders because of the nerve damage, autonomic neuropathy, multiple sclerosis, Parkinsonism, spinal cord injuries in patients of stroke, systemic sclerosis. In systemic sclerosis, smooth muscle fibrosis occur, and that will lead to decreased peristaltic movements. Now comes to the approach. So a patient comes to you with complaint of constipation. So history. First thing you should assess is the duration of the symptoms. How long are the duration of symptom? If they are a long duration, like more than 6 months duration, it is most likely a functional disorder. While if it is a new onset, like within a week or within few months, 2-3 months, patient has developed these symptoms, most likely mechanical disease. In the history, ask the description of the symptoms, whether patient is complaining of excessive straining, sense of incomplete evacuation. So that goes more in favor of a evacuation disorder. Treatment will be different. Or whether the patient is complaining of there is a lack of urge for defecation, that is a slow transit constipation. If a patient is describing that there is abdominal pain or bloating, so it could be related to the normal transit constipation as well. Diet history is important, whether there are adequate fibers in the diet or not, because the lack of the fiber do cause constipation. Amount of the water intake is also important. If a patient is taking less water, so obviously because of the dehydration features, intestine will absorb more water and stool become hard. So that history should be taken in detail. Physical activity, yes, exercise do improve intestinal peristalsis. So patient is sedentary, peristalsis will be less and patient will develop these symptoms. Medical history is important. Medical history of diabetes, medical history of any neurological disorders, or patient has systemic sclerosis, patient has hypothyroidism, whether it is controlled or uncontrolled, should be taken. Surgery history, whether because of the surgery there was some nerve injury or spinal anesthesia was given, or patient has undergone some cesarean. So these sort of history should be taken. And most importantly, warning symptoms. So with constipation, if warning symptoms are present, then that become an indication to go for a colonoscopy or further studies to rule out the malignancies or any mechanical disorders, because these mechanical disorders will respond to the managing the underlying cause. So what are those warning signs? Number one warning sign, always ask if a patient has constipation if there is a frank blood in the stools, which is known as hematochezia. If there is unintentional weight loss, like more than 4.5 kgs weight loss is there, it goes in favor of malignancy. Family history of colonic cancer, iron deficiency anemia patient has developed without any obvious reasons. Positive, occult blood is positive in the stools. Acute onset of constipation in older patients. Now, physical examination. So, physical examination is abdominal examination. So, look for the distension, whether peristaltic movements are slow down or normal. If there is any hard feces which are palpable in the colon, inflammatory or any neoplastic masses are there or not. And sacral dermatome should be examined for loss of sensation. There is a reflex, cutaneous reflex known as the anal wink. So just stroke the area around the anus, and if anal is not able to contract, then it means there is a failure of anal wink. So neuropathy or nerve damage is there. Most important is the rectal examination. So most of the physician, they hesitate to do a rectal examination. So but rectal examination will give us many important informations. Patient should be in a left lateral position. Perianal area should be examined under a torch, under adequate light, to look for any scars, fistulas, fissures, or any external hemorrhoids. And these are clearly visible if they are present. And also after the straining, just ask the patient to strain and see for the perineal descent. Normal perineal descent from the ischial tuberosity is 1 to 4 centimeters. That is a normal descent. If it is less than 1, that means the descent is less. If it is more than 4, the descent is more. So lack of descent, that means it is an inability to relax the pelvic floor muscles. Or excessive perineal descent means it is a descending perineal syndrome. Both can cause constipation. Rectal digital examination is also important. So it will give us the important information about a fecal impaction, any anal strictures, rectal mass, inability to insert the examiner finger. So anal tone will be assessed. Tenderness on palpation to look for any inflammation. Degree of descent of the perineum is also assessed. Investigations. So 90% of the patients of constipation does not need any investigations. So most of them can be managed just with a simple history, digital rectal examination, and lifestyle measures. So when to go for the investigations? Number one indication, if there is any systemic illness like pallor is there, you are suspecting electrolyte imbalance, so go for a calcium check, potassium check, blood glucose level to rule out diabetes, and TSH to rule out hypothyroidism. And if there is any structural disease, then we go for colonoscopy. Now let's see what are the indications of colonoscopy. Indications of the colonoscopy will be age more than 50 with a recent onset of symptoms of constipation, change in the stool caliber, like patient will tell that the diameter of the stool is reduced, heme positive stools, iron deficiency anemia, rectal bleeding, rectal prolapse, weight loss. So these are the indications for the colonoscopy according to the American Society of Endoscopy. So these features, presence of these features, any one of these features, then we should consider for colonoscopy. Now let's come to the flowchart algorithm. Constipation. Number one thing, always rule out secondary cause, because if you know the secondary cause, you treat those secondary causes, which are drug intake, medications, weight loss or blood in the stool, that is structural disease, mechanical obstruction, colonic cancer. Pain on the digital examination will suggest a fissure or piles. Abnormal glucose, thyroid test, electrolyte, it will be metabolic cause. So these secondary causes, most of the secondary causes ask these 4 points in the history or in the examination, go for a digital rectal examination. And also ask for the warning signs, which we have discussed earlier. So if any one of the warning signs is present, then colonoscopy will be indicated. Why? No warning signs, no secondary causes, it is functional most likely. So first, lifestyle modifications. If there is no relief, give laxatives. First give osmotic laxative, followed by the stimulant laxatives. Still no relief, then we will go for the balloon expulsion test or high resolution manometry test. If that is abnormal, most likely it is the rectal evacuation disorders. They respond to biofeedback. And if a balloon expulsion test or high resolution manometry is normal, then we will go for a colonic transit studies, or we can refer the patient to gastroenterologist, to the specialist. So this is the flow chart for constipation. A simple flow chart, useful flow chart. 90% of the cases you can manage just with this flow chart. Now, what are the lifestyle modifications? Lifestyle modifications ensure that patient should be taking 1.52 liters per day of the fluid intake. We have discussed the mechanism. If patient is dehydrated, water will be absorbed more from the intestine and stool become hard. Now, this is a very important practical tip. So practical tip is most of us, we use Western type of toilets. What we ask the patient, patient should place a 6-inch in height some stool under their feet, and they assume a squatting position. So what squatting position will do? Squatting position will straighten the anorectal angle and the stool will be passed easily. Also, after a breakfast, distraction free. Distraction free means no mobile in the toilet. So we have seen so many people, they go to the toilet with their mobile phones. They keep on sitting on the toilet. Their distraction is on the phone. Their sympathetic activity is triggered. So that will aggravate further constipation. So a distraction free means no mobile, cool and calm mind, 15 to 20 minutes on the toilet without any straining after breakfast. Because after breakfast, the peristaltic movements are increased. So that will help in building the routine of passing normal stools. Physical activity is of paramount importance. It should be increased, and fiber intake should be 25 to 30 grams per day of a soluble fiber. This is important. Soluble fiber should be given. And if patient is taking less fiber, do not ask the patient to go for a 20 or to 30 grams of fiber in a day in one go, because patient will not tolerate a sudden increase in the fiber in the diet. So ask the patient to gradually increase the fiber intake. Otherwise, patient will give you the symptom of more gas and bloating. So what are these soluble fibers? Soluble fibers are oat bran, nuts, barley, seeds, beans, lentils, peas. So these can be given. These are soluble fibers. So side effect of the fiber supplement, abdominal distension, bloating that we have just discussed, and poor taste. So what should be done? Patient should increase their dietary fibers gradually over a period of several weeks. Now, what are the fibers available in the market? That is Silemus, that is also known as isabgol, popularly known as isabgol. The dose is 4 to 6 grams per day, and important is कि it should be consumed very fast before the husk absorb the water, because if the husk absorb the water, it become hard. So it will be difficult to swallow and it will aggravate constipation. So very important practical tip: consume it very fast with gulp of water, and it should be stirred very briskly in half glass of water, and it should be swallowed at once. It is not a sip by sip, it should be taken in one go. And if still there is a difficulty, then carbonated water can be preferred. Spring carbonated water, it become slightly more soluble, and some patient they can swallow the granules and then they take the water. That is also important practical tip for its use. And but there can be a side effect that it can cause IgE mediated reaction also. So ask the patient, if such reaction occur, do report to the doctor immediately. Osmotic laxatives. Osmotic laxatives are either poorly absorbed ions or poorly absorbed carbohydrates. So they draw the water inside them and then they lead to the relief of constipation. So one of them is magnesium salt, like milk of magnesia. You must have heard the white colored liquid. So it should be taken 15 to 30 ml once or twice a day. It can be taken. It produces the stool movement within 6 hours. Now, poorly absorbed carbohydrate is lactulose, and the dose of the lactulose is 15 to 30 ml once or twice a day. And there is a measurement which is given there. So, for a precise measurement, 15 ml, 30 ml is given, and it takes 2 to 3 days for its effect. So, if the patient is not getting the effect in one day, so patient should not stop it. Patient should continue to take it because it might take 2 or 3 days. But important thing is that tolerance occur with the lactulose. So because of the change in the gut flora with lactulose, so tolerance is one important issue with lactulose. Now, stimulant laxatives, they increase the intestinal motility, increase water and electrolyte secretions. So these are the anthraquinones, which is senna, and after 6 to 8 hours, there can be a result. Castor oil, 15 to 30 ml, it is hydrolyzed and it inhibits the water absorption and stimulate the motility. Diphenyl methane derivatives like Biscodil, 5 to 10 milligram at bedtime can be given, and it can be given as a single time use also. Means ki just one day if we want to prepare the patient for some radiological investigations where the stool should be passed adequately. So this is given Biscodil. It works both on the small and the large intestine. Enemas can be used, and enema are fast acting. Within 2 to 5 minutes stool evacuation occur. Now, pro-secretory laxatives, some of the relatively new laxatives available in India are lubiprostone, then linaclotide with their mechanism of the action, 5-HT4 receptor agonist, that is prucalopride, 2 milligram once a day. So these are pro-secretory laxatives which can be used if the common stimulant laxatives are not effective. Now, important thing is anorectal biofeedbacks. So what exactly is that? Because that will be very important for the rectal evacuation disorder patients. So in this, patient are trained to relax their pelvic floor muscles during the training. They are given training and coordinate this relaxation with abdominal maneuvers to enhance the entry of the stool into the rectum. And there will be a stimulated evacuation with the balloon is also done during the balloon expulsion test. So this is also taught to the patient to emphasize the normal coordination of successful defecation. So the puborectalis muscle should be relaxed and patient position should be in a squatting position. So all these biofeedbacks are given, and multiple biofeedbacks, multiple days it is given for good results. Now the real cases. 71-year-old male. The main symptoms were difficulty passing the stool with incomplete evacuation. Patient has diabetes, but diabetes is under control. So we will think of autonomic dysfunctions. Patient is taking laxative for the 2 years, but still there is no improvement. Lab tests are within the normal limits. Electrolyte normal, no thyroid issues, no other medications for diabetes except for metformin. So this was the flow chart. So we will again revise the flow chart. First, rule out the secondary causes. Then we look for the warning signs. And if no warning signs, then we go for the laxatives. Patient is taking the laxatives, lifestyle modifications along with laxatives. No relief. The next step will be balloon expulsion test or high resolution manometry should be done. Patient was not taking any drugs. Patient does not have any weight loss or any blood in the stool. So secondary causes were not there. No warning sign was there. Still, the patient, because of age of 71 year, we asked the patient for colonoscopy just as a precaution. So colonoscopy shows these results, and in these results there were, you can see here, small internal hemorrhoids, which unlikely cause the constipation, but you can see here melanosis coli was present. So what is the reason for that black pigmentation of the colon? Patient was taking senna. Senna causes the melanosis coli, the typical side effect. And when the high resolution manometry was done, so anorectal high resolution manometry was done, and in that there was an inadequate relaxation of anal canal, and patient failed to evacuate 50 ml of rectal balloon over 1 minute test duration. So the Foley's catheter is inserted and 50 ml of distilled water or saline is inserted in the balloon. So patient will feel a urge for defecation, and normally patient will expulse that balloon in 1 minute time, but here patient was taking more than 1 minute of duration. So what was the treatment in this patient? Treatment was one session of the biofeedback was given. So it was appropriate treatment which was done, and patient was asked for the biofeedback therapy only. And when patient did biofeedback therapy, after 3 months symptoms were much better. Patient, medical student, complain of constipation symptoms, and in the history patient was using mobile while seated on the toilet, a very common problem. Skipping the breakfast to attend the morning lectures, less water intake, lab tests were normal. So what will you do? So here we will go for a lifestyle modification. As such, young patient, no warning signs, no need for colonoscopy. So we advise distraction-free toilet use after breakfast. Patient was advised to take the breakfast early and then go to the toilet and increase the water intake. Yes, patient improved. Our medical student improved. 45-year-old female, constipation 3 months, using fiber supplement. There was no relief, no past medical history was there. So then we look for this flow chart. So in this flow chart, we ask the history about drug intake and any weight loss and any abnormality in the lab test. So there was no abnormality, there was no warning signs in this patient, but the patient gave a history of drug intake. Patient was taking calcium supplements. So this is a detailed description of the algorithm, management algorithm. So patient was taking calcium supplement, calcium carbonate. So we advised patient to stop the calcium carbonate. Patient improved. So the most important thing is that you should know what exactly is causing the constipation rather than prescribing the fibers or laxative in the first visit. So this was about how to manage a case of constipation. So if you have any patients, you want to share your feedback or any patient experience you want to share, you can write us in the comment box. Thank you.